I'd like to thank you so much and thank you for the invitation. Really, it's an honor and a pleasure to be in this wonderful group here. Nothing to disclose. Inherent to laparoscopic surgery is the risk of conversion. But why do we need conversion rates? Why do we have to follow them, and why are they necessary? First, conversion rates are associated with worse outcomes. Most of the times, worse outcomes meaning longer length of surgery, more postoperative complications, longer hospital stay, and poorer short-term quality of life. But besides that, conversion rates were used initially to determine the feasibility of a procedure. If a procedure, when first laparoscopic surgery started, high conversion rates were an aversion, a deterrent to do a laparoscopic procedure. Nowadays, conversion rates can be used to evaluate the surgeon, experienced surgeon, lower conversion rates, evaluate patient selections, evaluate also possible indication for the procedure. But do we really have a definition of conversion? It's not as simple. Procedures like cholecystectomy, appendectomy, inguinal hernia repair, which are being done only through ports, extending the port is a definition of conversion. But in colorectal surgery, where you have to make an incision to get the specimen out, then things get more complicated. In what's called laparoscopic assisted surgery, how do we define conversion? And it is actually, an example of that is if you go down over the last decade in colorectal surgery, you see that there are very, very different definitions of conversion. When do you make the incision? How big is the incision? Do you do a step of the procedure, do the incision? Do you do vascular ligation? If you do the anastomosis through the incision, is it a conversion, is it not? So there is really a little bit of a chaos in defining, in these cases, conversion. But even now, recently, even in laparoscopic cholecystectomy, there's another way of looking into defining conversion. And the group of Lengel from Brigham actually put in the issue of effort in defining conversion, meaning how much effort do you have to put to get adequate exposure before you convert? If you don't put enough effort, then is this a conversion? What type of conversion is it? So there is a field that needs clarification. And actually looking up, a group from Netherlands, Blickendal, gathered gynecologists, urologists, and general surgeons and tried to clear this up. And they came up with a relatively good pathway. They defined conversion in two basic categories, strategic and reactive. Strategic is a conversion that makes after you assess the feasibility of completing the procedure. And you see that it does happen, meaning you go in laparoscopically, you assess the field. If you think this is going to, you anticipate difficulty is not going to work, then you convert immediately. This is a strategic conversion. Reactive conversion is if you begin laparoscopically, you either have a complication, bleeding, perforation, then you have to convert, or you begin your laparoscopic dissection, but after a period of time, they used 15 minutes. You see that it's very difficult to continue. So if you convert there, this is a reactive conversion. So I think this will be nice because we will see in the future difference in morbidity and possibly mortality within strategic and reactive conversion. Now, after this little introduction, going back to how conversion rates have gone over the years, I'm just going to pick a few procedures that we all do. We go into laparoscopic colectomy. I gathered here most of the prospective randomized control studies over the last years that compared laparoscopic with open colectomy. You see that since the last 10, 15 years, conversion rates have remained about the same, at an average of 15%. There's only a recent Japanese, the clinical oncology group that specifically in rectal cancer had shown a very smaller conversion rates, but the trend has been more or less the same. Now, if in colorectal surgery you select many of the non-comparison studies, which are well done, you see that there's a very wide variety of conversion rates. They go up from like 2 to even 40%. And if you see Gervas in a meta-analysis of 200 studies had a conversion rate from 1.9 to 40%. So we don't really see a trend coming down. It's really going up and down, up and down. This is definitely due part to not having a correct also definition of conversion. Now, let's pick laparoscopic cholecystectomy. It's a very common procedure. These are the major nationwide studies gathered since the last 10, 15 years. We have Livingston with a national USA study, Balal with a Great Britain study of 43,000 patients, Kafarani with a big VA study, and finally Harbo also with a large Denmark study. And we see that conversions, even through those large numbers, range to about 8 to 9%. We don't really see a trend going down. We have actually, if you look at Balal's case, where he separated acute from elective cholecystectomy, they did see a higher conversion rate, a little bit higher conversion rate in actually acute cholecystectomy. Now let's pick another solid organ, laparoscopic appendectomy, laparoscopic adrenalectomy. You see through the years, most of the series showed that conversion rates have even maybe grown a little bit higher, but definitely not going down. If you bring them up actually also through the last decades, and you split them through the last decades, you see the conversion rates have remained the same. Let's get to another example, which is maybe entices a little bit more to the etiology, part of the etiology. We'll look at laparoscopic appendectomy. This is Lee it's a very nice meta-analysis looking over a period of 20 years. So he gathered 44 prospective randomized trials looking at laparoscopic appendectomy versus open appendectomy. Now, the overall conversion rate over this period was about 9.5%. But look what's interesting. If you split those cases between the studies were done before the 2000, then you see that you have an average conversion rate of about 8%. Now, if you gather the cases after 2000, you see that you have a higher conversion rate. It's going up to 11%. And you see here studies with like 19 and 25 and 30%. Now, if you break down those cases, you see that 40% of those studies were with complicated appendicitis, meaning appendicitis that had an abscess or appendicitis that had a peritonitis or leprastron. So there's a trend that surgeons are getting into something more difficult, then you may expect to have not the same, but even sometimes higher conversion rate. And that's actually also being seen by, if you look at splenectomy, where Philippe Corianal looked at the conversion rates of splenectomy in comparison with the size of the spleen, which they measured preoperatively by CT volumetry. So they looked at the larger the spleen was, of course, the higher the conversion rates was, 41 and 87%. So this can get us into the discussion for all this session of why conversion haven't improved and what can we do to improve them. And if we want to just make it just 1 or 2 minutes, some thoughts of why conversions haven't improved and have remained the same, is we have to see what are conversions dependent on. Conversions are dependent first from the patient. Patient's BMI and ASA. Are we operating on thinner patients? Are patients becoming thinner over the period of time? I don't think so. Quite the contrary. Even in Greece, with our beautiful weather, we've seen that obesity, especially in young children, is coming to be an epidemic. So yes, BMI is going up. Are we operating on patients which are healthier? Not really. We get to operate on sicker patients with many comorbidities. So ASA status is going up. What about disease-related factors? When we started laparoscopic surgery, every surgeon had a learning curve. Of course, he had some high conversion rates at the beginning, but then after the learning curve, he wanted to what's called acceptable conversion rate. But even through our career, the first cases we selected for laparoscopic surgery were cases which were more straightforward, not complicated case. But as if you get experience, you get more aggressive, you get more confident, then you get to cases through the years which are more complicated. You're getting a size of the specimen you're going to remove, there's a phlegmon, there's an abscess, there's local invasion for cancer. And there you see that they're attempting actually the more difficult thing. You see that your conversion rate will be higher or at least will not diminish. Third factor is surgeon. Surgeon who does the surgery, his experience and his judgment. Of course, with more experience in laparoscopic surgery, you're bound to have a smaller or lower conversion rate. Although it was interesting to hear a talk today, bringing up the color study, earlier here at SAGES, that they saw that for rectal cancer, it's interesting, the facilities that had the higher volume of conversion, the higher volume of rectal cases, had the higher conversion rates, which is completely the opposite. You expect a surgeon that has many cases to have lower conversion rates. So that's where comes judgment, surgical judgment. When do you convert? So maybe if you're an over-experienced surgeon and you have many cases, you know when to do a strategic versus a reactive conversion. Would you convert earlier if you have the experience, you know that this is not going to work? So experience and judgment will influence, they have influenced conversion rates. And finally, technique and technology. New techniques, nodes, single incision surgery, and new technologies coming up. Of course, they're not they make procedures, even nodes and singles, more technically demanding. So that will need more experience, and that could influence conversion rate in the future. Just to conclude, conversion rates have remained overall unchanged. In order, though, to assess and to be able to compare, we do need to compile a uniform, multidisciplinarily, and applicable definition of conversion. Patient selection and definitely surgical experience and judgment are actually two factors that can be modified and adjusted to influence conversion rate in the future. But we should not forget that above all, safety comes first, and when to convert should be done with safety as your first vanguard, and we should never consider conversion to be a complication. Thank you, Mr. President.